So yeah, we're very happy to have Professor Tania Gergel join us today and speak to all of us. Professor Tania Gergel is Director of Research at Bipolar UK, Honorary Professor in the Division of Psychiatry at University College London, and Honorary Visiting Professor in the Division of Psychological Medicine and Clinical Neurosciences at Cardiff University. She joined Bipolar UK in 2023 in order to establish an in-house research division within the charity and is now a lead on multiple research projects focusing on bipolar and other severe mental health conditions, in particular issues surrounding suicide, as well as being a prominent advocate for lived experience involvement. In 2013, she moved to the IOPPN, King's College in London, specializing in mental health, ethics, law, and the phenomenology of severe mental illness, where her primary focus was the clinical, legal, and ethical issues surrounding the creation and use of advance directives in severe and episodic mental health conditions. Her work focuses on putting the lived experience of mental illness at the center of mental health research and policy, and she is internationally recognized for her work on bipolar, advanced directives, ECT, electroconvulsive therapy, and innovation within co-production. So we're very happy to have her here. So thank you all for joining us. And for those of you who have never been to an experiential science talk before, they're organized by the Center of Excellence in Youth Mental Health. I know some of you are from London, so it's probably the afternoon for you guys right now. So good afternoon, and thanks for joining us today. So I'll pass it on to Tania Gergel.
Oh, thank you. Thanks so much for the introduction, and thanks so much for having me here today. I've got multiple screens open, as is the way with remote talks. So if I'm juggling around at points, please, sorry about that. And also, I mean, I know that we're remote. I know there's quite a few people here, which is really great. And I'm going to try and, leave some time for discussion at the end. And it would be great if we can make this quite discursive. So I'll endeavour not to talk for too long. Right. So my talk today is titled Expertise in Mental Health, Bridging the Gap Between Researchers, Clinicians and Lived Experience. And I think that, the primary focus of today's talk is to think about and to discuss the different types of frameworks that might bring people with lived experience into involvement in work relating to mental health. And I suppose into work relating to medicine more generally as well. This isn't restricted to mental health. So I suppose, if there were a key message for today, I think it's that we can't reduce the involvement of lived experience into one framework. We need to think about it in lots of ways, lots of dimensions. And I think that we need to work towards a better recognition and a better understanding of all these different ways in which lived experience could intersect with research and with clinical work. So I thought that I might start by just talking a little bit about my own work and how I got interested in this area. So this sort of quick slide at the beginning, it's it's a little bit of a jumble, but it's probably worth just a little bit of background. I think it'll help because I can then explain the stuff that I work on. But it's also a bit the story of how I got there, got to where I am now, rather, and really kind of perhaps an example through one person's journey in becoming interested in the area of lived experience involvement. So the first thing to say is that I myself have lived experience of bipolar. This is something that's, I think, it's always informed my work in this area underneath it. And when I first started working in this area, which is about sort of 15 years ago now, I think, it was very much something that was underneath. So I didn't start working in this area identifying openly as a lived experience researcher or seeing myself as a lived experience researcher. And I didn't have an explicit focus on lived experience involvement. This was very much something that has grown for me. I wasn't really so aware of it either when I first started. The focus when I mean originally I started life as a philosopher in a very different area, but yeah, as I came into the area of medicine and psychiatry, my focus was on medical ethics and law, and specifically on mental health ethics and law. And that's finished a large part of my work in the field. And one of the things that I'll talk about a little bit today is the work that I've been doing in this area, specifically I've focused, a lot of my work has focused on something called, I think probably quite a few of you will be familiar with the term, on a, mental health advanced directives, sometimes known as psychiatric advanced directives, and in England and Wales, now known as advanced choice documents. And essentially, what these are is they are documents in which people with a chronic health condition, or in this case, a chronic mental health condition, they can use their previous experience of being very unwell to write down instructions as to how they would like their care to be organized if they became very unwell again. So the idea is it's a document that can kind of give a set of instructions and represent a voice for people at a time, when they may in the future become severely unwell again and not have the opportunity to have that voice heard, or not be able to make those types of decisions, not be able to give those instructions. So that's the sort of idea behind it. And people write them for all different reasons, either to request things or to say that there are things that they would rather avoid when they're unwell. And they can have different aims for different people, and different, intended outcomes for different people. And apart from that, the sort of focus, I suppose, within my work has been on severe mental health conditions, and particularly bipolar, especially since I've moved to Bipolar UK 3 years ago. But it's still sort of, I mean, there's so much that cuts across diagnoses and cuts across categories that, I find myself working broadly in the area, as well as this very specific focus on bipolar. And then the other things, you'll see up there, sort of co-production, or I should have said really just well, we've got co-production or lived experience involvement. So that has increasingly over time become a major part of my work. And by that I mean, oh sorry, it's go back to the, yeah, sorry, by that I mean the involvement, well, not so much, so lived experience involvement, involving people with lived experience of a particular condition in work relating to that condition, whether that's whether that is relating to services, or whether that's relating to research. And co-production is a kind of more, well, I suppose the way I understand it is a more enhanced version of this, in which people with lived experience of the condition are actually involved directing that work at every stage of the process. So really producing it jointly with people without direct lived experience, working together on all stages of the project, and working together in a shared capacity, where decision making is shared, where the work is shared between them, and where there is, input from lived experience in all dimensions of the project, really. And so the other factors, and once again, this is something which is relevant here, is interdisciplinarity. As I said, I've come from a background, I was a philosopher to start, and that's something that very much still informs my work. But, within mental health itself, a very kind of interdisciplinary approach, something that mixes ethics, mixes law, mixes clinical work, research, and looks at all different types of research and all different approaches to mental health and mental illness. And then the integration of lived experience, which we'll be talking about more. And as a philosopher as well, I think I'm very interested in conceptual investigation. So looking at frameworks and looking at concepts which are being used, and frameworks which are being used, and methods, and trying to understand, how are these constructed, and what might we, are there ways that they fit together? Are there ways that they could fit together better? Are there gaps? Are there inconsistencies? Are there areas that, that could be explored that haven't been explored? All sorts of things like that. So I think, that's a real key thing that sort of underpins everything that I've done and everything that I'll talk about today as well. This idea that, that we may be looking at a really specific topic with a really specific area of focus, but at the same time, we're always thinking about the framework that topic sits within, and whether that framework, whether the frameworks that we're using to investigate it, whether they're frameworks that fit, and whether the framework we're using fits, and that sort of thing. So I think it's something that's very important, and particularly important in relation to the area of lived experience involvement, which is such a relatively new area within research. So yeah, I'll let me talk about. I'll talk about now the first example that I was going to use. And sorry, Raven, if you don't mind switching the slides. So the first thing that I wanted to say is, I suppose, about the importance of lived experience perspectives. And I think we talk so much now about the incorporation of lived experience, and but I think there are different ways that we can approach this and think about it. So the most prominent way that perhaps that we talk about it now is about lived experience involvement in research or clinical work, or if done really fully, this sort of co-production model. And I think this is what most people are talking about when they're talking about the involvement of lived experience. And so it's really people with lived experience, explicitly in being involved in their capacity as having lived experience as researchers or clinical workers, in relation to the particular condition. But I think there's also another area, which is that it's incorporating lived experience perspectives as a source of knowledge as well, which we may do as lived experience researchers, or we may do as researchers who don't have lived experience. But it's the idea that actually, one of the sort of the one of the key sources of knowledge that we don't necessarily utilize as much as we could, in fact, we definitely don't utilize it as much as we could, is the knowledge that is held by the people who have lived experience of the condition. And yeah, there are different ways that we can use this. So we can use this knowledge, people working on research projects, people informing the research projects through being researchers, or, informing clinical work. But at the same time as well, if we think of it, we can also have sort of lived experience as research data, if you like, as the source of our knowledge. So bringing in the perspectives of many people with lived experience to gain a greater understanding of the condition itself, rather than just sort of being there as participants who are being observed or measured, but actually providing that information themselves. And I think this is something which is underutilized, and this is a bit of a theme in a lot of the work that I've done. So one of the key areas of work that I sort of started off in this area with was, as I say, research on advanced choice documents or advanced directives. And it was interesting working in this field. I sort of started looking at it very much from the viewpoint of someone with an ethics background, and I looked at the conceptual arguments and looked at the kind of ethical questions that people had around this, and the legal questions, and how the law fitted together, and found that the debate was very much, it was a strange sort of situation. I think people generally, there was a very positive attitude towards advanced directives. Internationally, there was a very positive attitude towards advanced directives. People saw them as something that could potentially have great use, and be, and this was sort of seemed to be across the board. But all the kind of main debate and the main research and intellectual discussion of this area seemed to be coming from quite a detached ethical and legal perspective, sometimes with a bit of clinical input, but mainly a very kind of, as I say, a very detached sort of ethical level. And what wasn't being, it struck me as curious that this advanced choice document or advanced directive, whatever you want to call it, it's an intervention. It's something which is designed to bring the voice of the person with lived experience, the service user voice, the consumer voice, into psychiatry, at a time when someone may be detained under the Mental Health Act, under mental health law. Someone may be in hospital, they may not be in a position where they're being listened to, they may be in a position where they themselves know in advance that their decision making may be compromised. And so this is about having that voice there. But the one group of people who didn't seem to be sort of in the loop in terms of being consulted and being asked what their opinion was people themselves living with these conditions, people with lived experience. So we would find that, so there would be one ethicist would say, well, there's a real difficulty here because if we let these go ahead, then you might find that people would become too distressed by writing them because they'd have to deal with thinking back to difficult times, or they may become, maybe the potential for someone to exert influence on them, or there were lots of questions, and these questions were were legitimate, but what was happening is these were presenting a block without actually going out to people and asking people what they thought. Or, some clinicians might say, well, look, people would start asking for all sorts of strange things, and people might not want this. People might prefer that other people were, with more expertise, were in the decision-making place. So what we decided to do was we thought, well, actually, we should just go out and ask people. So we ran a very big survey. We ran a survey. This was before I started working for Bipolar UK. It was my first sort of work with the charity. Using Bipolar UK as a partner, we ran a survey via Bipolar UK of their members, and had a really, really good response, which asked them loads of questions about advanced decision making and advanced care planning. And, what did they think of it? Did they think it was a good idea? Would they like to know more? Had they had experience? And we found there was a huge enthusiasm, and we also found that the kind of concerns that people had were not the concerns that were necessarily being expressed by legal scholars and ethical scholars and clinical scholars. They were different, and generally there was sort of it was straight. It was there was a kind of there were different views coming in. I mean, firstly, a massive enthusiasm and a massive interest in this area, but also different priorities, different concerns, different thoughts about, and also especially different thoughts about what the benefits could be. So, really, really fantastic ideas coming forward about why it was so important that we had these, and actually, that it was that there should be less things standing in the way of these advanced choice documents coming into being. And so it was and also we did some very detailed analysis on some of the qualitative information that came in, the answers that people gave. And it just happened that in answer to a particular question, a lot of people started to talk about not that they were asked directly about it, but this was how they answered. They started to talk about their own experiences of being unwell with bipolar and having severe health crises. And a lot of people talked about the fact that their decision making was affected by their illness very severely. They started to talk about decision making capacity. They started to talk about things like suicide. They started to talk about not being in control of their thinking. Sorts of things like, well, there were some who were very opposite to that idea, and some said, I find actually the issue is that other people don't think I have capacity when I'm unwell, but I do have capacity. But a lot of people saw this, sort of came out with very, very, very articulate and very clear thoughts about what happens to themselves, that they change, whether this thought of kind of changed identity and changed thinking and decision making when they're severely unwell. And for me, as someone who lives with bipolar and who experienced many health crises myself, this wasn't a surprise in the slightest, because it resonated very strongly with how I understand things for when if I look back on when I've been very unwell, and on my own ideas that I put down in my own advanced decisions. But what was interesting is that when we sort of showed these answers to the research community and to psychiatrists, people were really amazed, and people were like, wow, people have such interesting insight and such understand, and it was like a revelation to the wider community that people had this own understanding of what happened, such a clear understanding of what happens to them when they were unwell. And also, that there were, while there were people out there who wanted to emphasize that actually that they were more in control of their decision making when they were unwell than had previously been understood, there were lots of people out there who in fact wanted to say, well, actually, I recognize that my decision making becomes is very different, has changed completely, and doesn't reflect my real priorities when I am unwell. And I may want other people to be able to make decisions. And I want to express my opinion now because my opinion would be radically different when I'm very unwell. And all of this sort of came as I think, as a big surprise to it was incredibly informative for our work and incredibly informative about how advanced choice documents should develop. But also, it was really interesting for me because it showed me that as someone living with the condition and knowing many, many people who live with the condition and having talked a lot to them about their experiences when unwell and how they understand those, that something that seemed very understandable and natural to me was something that actually a lot of the psychiatrists and the researchers that I were working with were very surprised about the responses that came in. Really, they didn't know that people would necessarily have that kind of recollection and understanding of times when they were severely unwell. They didn't know that people would be, would want to say that actually I change when I'm unwell and these things happen and my thinking gets distorted and those sorts of things. It was it was very interesting, and made it sort of made me aware that we should always that one source of knowledge that we're not drawing in and that we should draw in is is the we can't that we there's a limit to how much anyone else can understand what is happening when someone experiences a severe episode of mental illness, a severe mental health condition. There is a limit to how much anybody on the outside can understand. Really, the only people who have full insight and full knowledge of what is happening inside someone's head is that person themselves. And so, but this is yeah, I think there are a lot of stuff that we say that we don't know completely or we don't understand, when actually what we haven't done is gone out and clearly we can't just go to one person and say, what happens to you, and take that as complete understanding of what happens to everybody. But in research, we have the tools to speak to large numbers of people and to bring that knowledge together and to see that that there may be a variety of different things that people experience, but may also be sort of certain commonalities and threads that run through. So that was something. Anyway, that's about. So I suppose that was my first sort of. That was one of the first things that happened, and it was perhaps it's not necessarily what we think of lived experience involvement, but it was work that was so informed and driven by collective lived experience as a source of knowledge. So now I'm going to move on to talk more about lived experience involvement as we think about it. And if you don't mind doing the next slide. Thank you very much. So this is the Brain and Genomics Hub, and this is one of the big projects that I'm currently involved with. It's a 5-year project, a multidisciplinary project, and it's transdiagnostic. So we're trying to, cross over the diagnostic boundaries between bipolar and some psychotic conditions, and look at what might be common patterns, rather than sticking to particular diagnostic categories. And there are lots and lots of different factors that we're looking at and trying to bring together. So we are looking at lots of different sources of information. So social information, developmental, lots of biomedical information, neuroscientific and genomic, and also factors relating to lived experience. And one of the things about it as well is, but this time became very interested in and I'd started working in the area of lived experience involvement and wanted to use the Brain and Genomics Hub as a place to try and implement quite a sort of an innovative movement, an innovative approach to lived experience involvement. So we've got what we think is a relatively complex and innovative strategy for co-production and lived experience involvement. And clearly, what we're really trying to do is trying to address some of the barriers and the gaps to lived experience in complex mental health research. So some of the key barriers, and I'm sure that this will be very familiar to a lot of you in terms of lived experience involvement, is that one of the things is that often it's not representative of the population of people with the specific mental health conditions which are being considered and researched. This is particularly the case for severe mental illness, for bipolar and for psychosis. So people with the most severe mental health conditions are rarely included, and often this is, it might just be because it's seen as too difficult or people might be too unwell. Often the studies that work on these areas, even if they have lived experience involvement, it will be people with experience of other mental health conditions or exclusively sort of family members, rather than people with direct experience themselves. Another thing is that often it's a very small group of people who have the opportunity to give input into a project, and it's very restricted, and often it can be, certain sort of quite restricted demographically, and there's a lack of diversity in the group which is involved. Another thing is tokenism. So there's often a very limited input of people with lived experience into a research study. Often it's people who are involved a bit at the beginning and a bit at the end and do things like reviewing the participant information forms, but there isn't really thorough input into the design and delivery which goes throughout the research project. um, Another thing that happens is there isn't really a big framework for documenting or evaluating lived experience involvement and for looking at the impact of that. There aren't really established methods. There's not many sort of, and no sort of really well recognized methods for reporting that and evaluating it. And also, the sort of type of studies, often lived experience involvement is restricted to studies that focus more on the psychosocial elements of mental health or on qualitative studies. And there hasn't been so much real sort of integration of lived experience involvement into very complex multidisciplinary and biomedical work. Um, so what we wanted to do was to try and, aim, obviously we can't meet all of those challenges, but to try and meet some of them. And we sort of put together a relatively ambitious program. So one of the things is that lived experience is embedded at all stages of the project. And, we have lived experience, people with lived experience within the central research team for the duration of the 5-year project and before, in fact, in the design. Um, and and when I say people with lived experience, the project focuses on people with bipolar and psychosis. So this is people who have lived experience of bipolar and psychosis, who are the lived experience representatives for the project at all stages. And so one of the things we wanted to do to kind of we wanted to get a wider input into this as well, not just from a small group. We do have a small group of people at the centre, because we need to have a group that's coordinating, and I'll say more about that in 1 second. But what we want to do is we've got this idea here. We've put from research participants or cohort to research community. We want to give, when we consented people into the study, we asked everybody who's being consented into the study whether they would also like opportunities to get involved in lived experience advisory work in paid opportunities. And so we're trying to recruit 600 people for the study, and our aim is to have really a minimum, I hope, of 150 people involved in some form of lived experience involvement and advisory work. And also we're hoping, and we've been doing this already, to feed back to the participants about the study and to have community events, things like the launch, to try and really try to help people feel that they're not just coming along for one day and having their data taken, but they're really involved and invested in the study. And so I'll just talk a little bit about how this might work. And sorry, do you mind passing the next slide? Thanks very much. So in terms of how this works, we have the sort of the central hub research team, and this includes people with lived experience at a leadership role. We have something called the Expert Lived Experience Advisory Panel, and I'll say something more about that in a second, that is people who have bipolar or who have a diagnosis of bipolar or diagnosis of a psychotic condition, but also have experience in research. And so they're very central to the project and helping to research and advise on all different parts of the project. And then we've got the wider research community, the people who are enrolling in the study, who are being offered these opportunities. And what we're doing is we're trying to create different kinds of opportunities so that we can get people who wouldn't typically be involved in lived experience involvement work. We're trying to create opportunities that will allow them and give them an opportunity to get involved and to reach out to communities and people who don't typically get involved, so that we can get a much bigger range of people, but also a broader range of people involved in this, and hopefully be more representative input coming in. And the other thing that we're doing is we've created something called an impact log, which is based on a previous project that I had. And it's what we're doing with this is it's a framework to report and to evaluate the impact of people's involvement, people with lived experience, of their involvement in the research project. And I won't go into details about it now, but we've got it out there as a preprint at the moment, and we're just working towards submitting it for final publication. So the reference is there along with the forms. But essentially, what we've tried to do is create a toolkit that could be used in other projects as well. And I suppose one important thing to say about it is when we say impact, we mean impact in the sort of traditional sense of impact on the design and the delivery of research, but we also mean impact on the individuals who take part in lived experience involvement. And so we are giving the forms, the feedback forms, to everyone, to the researchers who don't have lived experience, to the researchers who do have lived experience, and we're asking them about specifically what questions were raised and what changes it made to the project, but also about the experience they had. Did they feel that they were listened to? Does it feel that it's, what's happened for them as a result of taking part? So trying to understand the interpersonal components as well of lived experience involvement. And I think so. That's about that. And then I was going to one of the ideas. So I've said that we've got this sort of specialist lived experience advisory panel, people with the experience of research. And sorry, can I take the next slide? And I think this idea of dual expertise was probably the idea that kind of, I think, personally put me in touch with. This was when Raven contacted me, because I think they'd read the piece that I'd written on this, and so I think so. Dual expertise. What I've done, I think that what's it's essentially it's an articulation of a very kind of simple notion, which is that we shouldn't necessarily create a binary distinction between people. We shouldn't create a binary distinction between people with lived experience and researchers. And so what I've done here on the slide is I've got, you can see on one side with this big heavy line between. I think that what we do is I've found working as someone in this field that I tend to be confronted a lot by this sort of binary distinction. Are you here as a researcher? Or are you here as someone with lived experience? Or are you a lived experience researcher? Or are you an academic researcher? Or something like that. And I don't know. I think it seems from discussing this with a lot of people over the last few years that this is something that is very familiar to people who are working in the area, but also have lived experience. And I think we draw a distinction. What we find is on one side of the distinction, we think of people as clinicians or researchers, and we think of them as having clinical or research expertise, having academic training and education, and if you like, an objective source of knowledge, and also being healthy perhaps. And then on the other side of the distinction, we think of, well, this is someone with lived experience, their expertise is through experience, their education is through experience, the knowledge that they have is largely subjective as opposed to objective, and to a certain extent they're well, people don't really call them unhealthy. They talk about healthy participants or healthy research, but there's a sort of assumption that the person is on some level unhealthy, unwell, or more vulnerable than other researchers who don't have lived experience. But what I've realized, and it's not just me, but so many people out there who work in this field. Actually, people have both. People have lived experience of all sorts of different mental health conditions and health conditions, and may well work in a field which a field that focuses on those health conditions. And it may be that they have been drawn into that field because of their interest in that particular area. It might have been that they were working in that area when these conditions developed. It could be all sorts of different things. It might be that they've got a family member, a very close family member, and that has drawn them towards working in this area. But I think that what we need to do is sort of move beyond this binary distinction and think I'm, clearly there are researchers and clinicians who don't have direct lived experience of the condition that they're researching, but there are definitely researchers and clinicians who do. And what I want to say about it is that, it's something that's already there. We're not suggesting adding something new. We're not saying, well, we should have this new category of people. What we're saying is, well, actually, there's this big category of people who are out there who, you know, maybe people who have disclosed, maybe people who aren't disclosing, and maybe one of the reasons that they're not disclosing is because they feel maybe this is something that's their own experience is really informing their work, but they're not disclosing it because they feel that if they did, it might compromise their reputation as a researcher or as a clinician, or people might only see them in terms of their health condition, or all sorts of different. I mean, so many people have different experiences and different views on this and different reasons why they have disclosed or why they haven't disclosed, or negative experiences of what's happened when they have. But I think that essentially this is a source of knowledge. This sort of dual expertise, this crossover, is something that we could really use, and we could, it's already there. It's not something that we need to create. I think it's something that could help bridge the gap, because the thing about research is that a lot of it is highly technical and a lot of it does involve specialist knowledge. But if you had people who have, well, what we're not saying, one of the most important things about it is none of this was intended to say that we should replace the idea of expertise through experience, or replace the idea of someone being a lived experience researcher with a category of dual expertise researchers who kind of somehow have more than that. It's really important within research that all perspectives are represented, and the perspective of someone who doesn't have a research background is enormously valuable because it hasn't, if you like, been biased by coming from within that research and academic framework. But at the same time, people who have a research background or a clinical background but also have lived experience, they perhaps can help to bridge this gap that exists between researchers and the lived experience community. And that's how we're trying to use it in the Brain and Genomics Hub. We want to bring all sorts of people who may have never been involved in any kind of research study, and everything might be strange and different to them. We want to bring them into a position where they can actually input into the study and advise. But to do that, we need people who can relate to their perspective of their experience, but equally have some technical knowledge so that and can bring that to them as well. And so I mean, at the moment, it is all a bit of an experimental stage. This is us just trying to do it within the context of the Brain and Genomics Hub, and then trying to sort of spread those ideas more widely and kind of spread those ideas around, and see what people think of this idea of dual expertise and having this kind of dual research or clinical identity. But I think I think there's been quite a strong reaction from people I know, in terms of lots of people have come and sort of said this is something that really resonates, and that's been fantastic to hear. And I think it's something that I'd really like to do more with and know more about what experiences people are having, and think with collectively with everybody about how this very special kind of crossover knowledge could be used. And for my final slide, I'm going to talk a little bit, just, I mean, not. I sort of should have, well, not a trigger warning, but I mean, I know it was said in the introduction that a lot of my work focuses on suicide. So I will just be talking a little bit about research into suicide and bipolar, and apologise in advance if any of this is potentially distressing. I hope it wouldn't be. But so one key area of my current research and the research that I'm trying to build up, and the reason why I'm talking about this now, is because I think it's a key area where this absence of input of lived experience involvement has really impacted and meant, and has really sort of stood in the way of progress in the area of suicide risk prevention in relation to bipolar, and many other areas as well. Um, so so this in terms of, I don't know how much people know about bipolar and suicide, but there's a very high suicide risk in bipolar. Suicide deaths are a major contributory factor in premature mortality, and some really sort of shocking statistics relating to this, where we think that somewhere between sort of 20 to 50 or 60% of people with bipolar will at some point make an attempt to end their life. and, or even more than one attempt. And there's a very high loss of life to suicide in bipolar as well. We're not sure of exactly the statistics, but we think, well, this is a stat that says 15 to 20%. It may be, as far as we can establish, somewhere between sort of 8 or 9% and 20%. But whatever the precise statistic, it's a shocking statistic, and it shows that the phenomenon of feelings of suicidality and suicidal behaviors are very much interwoven for many people with the experience of living with bipolar and that risk. And so one of the things we know is that there's a huge discrepancy between how suicide, sorry, I'm just thinking of the, yeah, there's a huge discrepancy between how suicide in bipolar is experienced and how it's understood clinically. I've just gone to the final slide. Thanks. Thanks very much. And what the research reveals is that there's a really significant divergence between the clinical understanding of suicide in bipolar and the lived experience of suicide. And there are lots of, ways that this discrepancy manifests. And some of it is that a key feature that happens is the many people who lose their life to suicide with bipolar are assessed as very low risk, see someone from health services and are assessed as low risk in the days or the weeks prior to suicide. Also, there's a sort of widespread view. Another factor is a sort of widespread view that suicide is something that's rare, that it's very unpredictable, that there isn't a genuine lethal intent, and that we can't conclusively link it to severe illness. But we know from people with bipolar that none of these things really relate to how suicide is often experienced in the context of bipolar. So lots and lots of different things, but I won't go into all the details about that now. I think, why is my research drawn to this, to understanding and reducing suicide in bipolar? Well, my own personal experience, but the primary thing, the need to reduce the level of loss and damage that this causes and our failure to make progress in this area. And, a key thing is that suicide research lacks input from people who have survived an attempt to end their life. And the understanding of how suicidality manifests in bipolar is very limited, and often it doesn't reflect. So we see this huge discrepancy between the accounts that people give of feeling suicidal and being suicidal, and the kind of accounts that we see in the textbooks of how suicide manifests in bipolar. And this is a quote from someone else, from David Webb, which says, my experience and my subsequent research and making sense of it has shown me that the greatest flaw in our current thinking about suicide is that we don't understand it all well. In particular, current thinking about suicide prevention doesn't appreciate or give enough attention to what suicidal feelings mean to those who experience them. So this is a real gap. And I think that one of the things, and this really brings together all the threads that I've been talking about, I think that if we are to improve our research on suicide in bipolar, that we need more input, and input at all levels and leadership from people with a direct experience of bipolar and suicide, to try and get through those discrepancies, so that the very investigations that we're doing and the models that we're using, the frameworks that we're doing to identify, to investigate this area, are informed by experience and informed by the reality of what this is like. But also, coming back to what I was saying at the beginning, the idea of lived experience as a source of data as well. A lot of people say, well, we can't make progress in this area, we don't understand it, because we don't understand what drives someone, because if someone has ended their life, then they're not there. But we have vast numbers of people with bipolar who have survived attempts to end their life, who have been in that position, and who could give us the information, who could provide us with so much understanding. And it's something that we're starting to begin to make progress on, but definitely where I want to kind of take research in the future. And I'm going to bring it to a halt there, because I can see there are questions, and I've talked for long enough, I'm sure. So I'm going to leave it to questions. And also, one of the questions I want to ask you, I suppose, is how people feel about this idea of dual expertise. And thank you very much for listening, everybody.
Thank you so much, Tanya. So I'll just jump in the chat here. So I see that Irnaz had a question. I'll just read it out. So, was there a difference in suicide rates between clients who were or were not prescribed medications? And if so, what was the difference?
Oh, thanks so much. No, really, really interesting question. I think that unfortunately there isn't really the level that there's a real gap. I mean, there's a real gap in research relating to suicide in bipolar. So I don't think that we can answer that question accurately. Some people, people will say that severe episodes of illness are associated often with a period if someone has, come off medication, and that may well be the case. And given that suicide may be associated with severe episodes of illness, it may be the case, but equally we are not very successful. I mean, lithium lithium is thought to be to have good effectiveness in preventing suicide in people who respond well to lithium. So if someone responds well to lithium, there is a high chance that lithium will help in in sort of in lowering levels of suicidality. But unfortunately, there are many, many people with bipolar who don't necessarily respond well to lithium. For example, people mixed states often. So what this means to say is that we don't. Yes, potentially. I don't think that we have the level of research to give a categorical answer to that question. Um, but also, we we don't have really adequate treatments for many people who experience suicidality in bipolar. There's a lack of understanding and a lack of research and a lack of effective treatments for a lot of people. So, um, sorry, that's a very complex answer without any really conclusive answer as well. Sorry, I can, yeah.
So next we have Haswin. Haswin.
Hi, Tanya. Hashwin here.
Hi, Ashwin.
Great talk. And once again, thank you so much for your leadership in championing the lived experience cause. My question is to do with the differences I see between clinicians and non-clinical researchers, so the basic scientists, with regard to engagement with lived experience collaborators. I think clinicians seem to have a lot of experience dealing with lived experience, like patients, PPI involvement, and that sort of a thing, and it's fairly entrenched. But there is a much wider gap I see when it comes to sort of with the non-clinical researchers, in terms of engaging lived experience collaborators. And there is often apprehension and perhaps some kind of a misplaced fear sometimes too. So I guess what they think is, lived experience collaborators somehow going to come in and tell them what they're going to do. And anyone who's been to graduate school knows that researchers are not amenable to suggestions from anyone, let alone lived experience collaborators, right? So I guess my question is, how do we sort of address that, bridge the gap, and sort of take a sort of a non-confrontational approach, but at the same time sort of addressing the concerns and perhaps make them see the value that lived experience can bring to the table. Thank you.
It's a really interesting question. Thanks. And I think there are different challenges. I would say that there are challenges working with research with academic clinicians, so with researchers who have clinical experience and with researchers who don't have a clinical experience. So I find that sometimes working with researchers who do have clinical experience, I mean, yes, they are more familiar working with people with lived experience, and many of them do sort of feel more comfortable in that environment, but also I find that quite a few of them can come with assumptions because it's the case that people work primarily that are, people working in mental health care work primarily with people who are severely unwell because of the lack of resources and the lack of sort of continuity of care. Their experiences working, often is working in a hospital environment with people who are severely unwell and really not being able to kind of shift out of that framework and finding it hard to sort of move beyond that kind of move beyond the sort of assumptions that they may have built up about people who are living with severe mental health conditions during a severe crisis. So that can be a barrier and can be an obstacle, which it sort of needs to be overcome. For people who don't, I mean, it's interesting actually. Hashwin's involved in the Brain Genomics Hub. He's one of our expert lived experience advisory panel, which is so it's great to have him here. But we're actually some of the early career researchers in the Brain and Genomics Hub have just come to us and have actually suggested that they just don't know enough about the conditions. They've sort of come in as biomedical researchers, or they've come in as qualitative or whatever researchers, and they don't. So they're, in fact, one of the things that they've asked us recently, and we're trying to put this together soon, is to get people involved in the study as participants to come in and educate researchers who don't have a clinical background about the experience of living with the conditions. And I think that that's something which could be really, really valuable and important because, what I suppose it's something that we forget. We sort of assume that people will have a knowledge of the conditions. And I think that's perhaps one way that, I think that's something that could help.
Thank you. Yeah, I think we're coming up with, along with Lena, an initiative in that direction. Perhaps maybe we can, sort of matching. It involves matching lived experience personnel with graduate students, for example.
Great. Oh, well, that's excellent. Well, we should talk. We'll definitely talk about that because it will be brilliant to maybe we can work together, the two projects, and sort of, create a sort of framework for it. That'd be fantastic.
Sure. Great. Thank you.
Marte?
Hi, thanks so much for the talk. This is very interesting and insightful. I had a question about this idea of like dual expertise. So,
Yes.
I'm just wondering to what extent the objective knowledge that you gain after your subjective experience might influence in return how then you report your subjective experience. So, say, let's take an example. I'm someone who has a history of a suicide attempt, and then later on, I learn about the interpersonal theory of suicide by Joyner. And then I start thinking back about my experience of suicide ideation and attempt and start thinking that, well, yeah, of course, that all these interpersonal processes maybe played a major role. And so I rethink my narrative, and then some elements are going to kind of take a bigger importance than they would have if someone would have just asked me spontaneously, okay, what do you think were the main contributors to your suicide attempt? So I'm just wondering, how do you balance the objective knowledge after the subjective experience, um, so that we can get real, genuine, and original insights about what you actually felt without being influenced by what you might know? I don't know if that made sense.
Yeah, no, it absolutely does. And it's such a fascinating question. And I think it's really at the heart of, I think that anyone who works in an area where they have experience, it's something that they grapple with, I think. And I think you grapple with it at every stage and you never really sort of, it's, I don't have an answer as such. I think it's something that every individual probably reflect upon. I mean, one question that does come up, and not usually from lived experience audiences, is the question of, if someone has lived experience, then how can they be objective? Because they'll be thinking about, and one of the things that we say, well, as soon as someone gets drawn into a research environment, they're drawn into an environment where you kind of move away from your own. You're in this position where you're informed by your experience, but you're, as a researcher, you're trained, you become trained to think in terms of collective experiences or experiences that reflect diverse experiences, sort of thing. So, and then it's kind of, how do you integrate that with your own? I mean, as I say, I think it's a really fascinating question, and I think it's something that it's one of the areas about dual expertise that I would really like to understand more about how different people. I know how I manage it at different times of my life and career, and different, and I couldn't say there was one way, but it would be so interesting, I think, to understand. So sorry, that is not an answer to your question. It's more what a fascinating question. I'd really like to think about it more, if that makes sense.
Yeah, thank you.
Okay, I understand that we're going a bit past 11. That's totally fine, but I just want to let everyone know if anyone has to head out. We understand and thank you for joining. We're going to continue on with the questions. Sarah Jeannie?
Thanks. I think Anthony, you had your hand up first, so you can go ahead with your question, and then I'll go after you.
So you spoke of that, and I wanted to have your opinion on something else. I don't know if there's the equivalent in the UK, and it's treatment orders. So under Quebec's law, and it's a different sort of system. It's based on civil code, but there's the equivalent in the rest of Canada, where the legal system is similar to the UK. So basically, forcing someone to be administered a treatment, and the criteria for this is that it's based on their inability to consent. So you basically sort of argue that the illness itself interferes with their capacity to understand what is happening, and you can then enforce treatment, and that can be very intrusive. And that requires here in Quebec the highest court, the Superior Court, and the judge then determines. So it's a sort of lengthy process, but it's used quite often and frequently. I think the system itself can be abused, and the lived experience of having a treatment forced upon you is in general sort of very negative. And I think it's probably experienced as something that um, uh, uh, something that it's difficult to defend against the medical expertise that supports, promoting such treatment. So I wanted to know what is, in terms of your perspective, which is different from ours, what are the legal, ethical consideration that you find important? If there's certain resource or reflection about lived experience about this, if you could sort of point out to certain literature or publication around this, I'd be very interested in looking at this.
So would that be in relation to advanced decision making and coercive treatment?
So my understanding of advanced directives is that you sort of agree beforehand to a certain treatment when you are recognized to have lost your ability to consent, and you've already pre-consented to certain treatment. Um, uh, but here, that is in the case that the patient adamantly refuses treatment. This occurs sometimes in the inpatient context, but also outpatient. And yeah, it becomes a coercive way of administering treatment. And
Yeah.
usually
So
it's for a few years.
I mean, there are there's definitely sort of legal frameworks everywhere. I mean, in the UK, generally, people usually when there is compulsory treatment, involuntary treatment, it
Yeah.
happens within an inpatient context under the Mental Health Act. And although there may be capacity assessments and capacity is associated with advanced choice documents, generally it's done on the basis of risk. There is also in the UK something called the community treatment orders, and these have been really controversial. They were introduced with the last Mental Health Act, and there was hope that with current revisions to the Mental Health Act that they would be taken out, which they haven't been completely. I mean, there's been tighter regulation on those, and that will be that someone who is actually living in the community but is known to come off their medication at regular intervals, and that is perceived to be a risk, is under a community treatment order by which if they don't take their medication or have injections on a regular basis, then they can be returned to hospital as seen as sort of non-compliant with their medication. And those have been enormously controversial. And I've written myself on on community treatment orders and sort of on the ethical issues relating to those. In terms of advanced directives and involuntary treatment, I mean, what we've found is that one of the reasons why they are so popular is because they've been shown to be one of the sort of interventions that's out there that can reduce involuntary treatment. So it's hoped that by someone having one of these documents and by sort of saying, these are the signs that I'm becoming unwell, this is what needs to happen if I'm becoming unwell, that we can actually get to a stage where someone could be treated or could be offered the treatment that they need before it got to a point whether they would be detained in hospital and treated involuntarily. But we did find one of the things that came out of the survey was also that we found that some people recognize that actually that they hope that they won't become severely unwell, and there are steps that could be taken perhaps to reduce that risk. But if they were to become severely unwell, that they themselves recognize that in the past they've needed treatment, but they have refused treatment. And so it's actually almost an advance request and consent for involuntary treatment. We call those self-binding directives. So I've done a lot of work on those as well. And particularly for people with bipolar, there's a lot of people out there who are quite favourable towards the idea of a self-binding directive. But the one thing we have found is that when people create an advance directive, that actually often it can lead to earlier intervention and a better understanding amongst the person themselves, amongst their family, and amongst the clinical team, which then often results in managing to step in or provide treatment or, give access to treatment at a stage before it gets to that kind of crisis point when it's felt that the individual needs to be treated but is refusing treatment. So sorry, once again, a long-winded answer, but and if you'd like to know more, I can definitely do email me and I can send you some more information about any of those areas.
Thanks a lot.
Sarah, Jeannie?
Thank you so much, Professor Gergel, really for sharing your own experience and all of your excellent work, and then a really very interesting talk. My question it comes in with relation to the complexity that we're dealing with mental health, right? So you have, like the way I look at it, and I'm so happy you talked about the genetics, because the genetic data has really shown that, right? We try to box them into categories, and the more we did that, the more the genetic findings show that there's so much overlap between everything, right? And so, like, the more I think of it, it's like a color spectrum. You have all of these different shades in between, and so when you have a voice that's addressing lived experience within a research setup, like, I'm concerned whether that really reflects, in a way, everybody else who might have had a different experience. And I just share my own experience because I've had two sisters, both of whom have passed away, but one had paranoid schizophrenia and the other had schizoaffective disorder. One of my sisters hated medication. The other sister was exceptionally compliant. And I just imagined that if I brought both of them to the research table and I said, "What is your opinion?" they would never agree on anything. And then spearheading that was my mother, who had bipolar, who had neither of the who had a presentation that was different from both of my sisters. And she was my mother. So I put it into the genetics context. And I was like, wow, this is complexity that I just cannot grapple with, even myself, even as a researcher and everything as a scientist. So how do we then, refrain from doing a disservice to those who don't speak the loudest, right? Because the person who's very quiet is not going to make it at all to the research table. And in fact, a person who's very sick, sorry, I'm sure you know what I'm trying to say. So how do we
No, not at all.
Not to do that disservice? So
yeah, no, absolutely. I think everything that you've said is so important, and thank you so much for sharing your experiences with us. That's a fun, an incredible illustration of the diversity just within the framework of one family. It's astonishing, how, and I think we have to be so careful as researchers and as lived experience researchers that we don't think that one experience reflects everybody's experience. And that's true whether someone has lived experience or, is a clinician or is a researcher. It's very easy to think that one particular model fits everything. And so that's, I suppose, one of the things that I guess what we try to what I think that it's something that's why I like I suppose I like the dual aspect, because I think as a researcher, if you're trained properly, you'll be trained to try to see beyond your own experience, but you don't have to have years of research experience to do that. So if you're facilitating lived experience involvement in a project, then I think it's like incumbent on all of us who are doing that to try to get people involved who wouldn't, who might have the quieter voice, as you say, or might have a different opinion, and to try to bring them in, to draw them in, and to try and provide an environment where their voice can be heard, but equally their voice can be integrated with other voices, so that we can, hear a vast and always be sort of be mindful. I guess that's why one of the things that we tried in the Brain and Genomics Hub, it's the reason why we're trying to bring so many people in. It's because we want to try. Look, we can't capture everybody. One project, even if we get 150 people advising on a project, that's not going to capture everybody. But if we all try to sort of broaden out and to try and bring in other perspectives, then we'll get a kind of what we don't want to do is just have one sort of cohort of people who become the people who are advising from a perspective of lived experience with the sort of. And I think also, I think that it's something that we need to teach the research community and the clinical community, that if you have people who are lived experience researchers working on a project, they're not just there to come in and say, well, my experience is X. So when people first said to me, well, actually what I'd really like to do is hear about their experiences, at first I was, well, that's much more that. So I think it's really important, to teach the research community that lived experience involvement is not just about an individual coming in and sharing their own individual. It's about hearing a multiplicity of voices to try and reflect the diversity, and always bearing in mind that there may be an experience out there that differs. How can we integrate? I like the qualitative. I mean, although a lot of the methods that are being used in a lot of the research studies because it's such big numbers, are quantitative, but I do like the qualitative ethos, that just because one voice is, that with thematic analysis, for example, when you're doing that, but because there's one idea that emerges just maybe from one person, whereas another idea might emerge from 10 people, it doesn't necessarily mean that idea is not an important idea, that could not be massively reflective of a really important truth about how that's experienced by someone. And I think that that's something, I guess it's like the other question that came out, it's like a balance, I guess, we have to have as researchers, always drawing on particular experiences or particular things or particular bits of knowledge that we've acquired, but at the same time being aware always that there may be other experiences and other knowledge that is different. I hope that answers a little bit.
Yes, thank you. Yeah, especially your summary at the end, we just recognize that there is that, and that itself is actually fantastic. Thank you.
Yeah, no, not at all. Thanks so much for the question. And I think it's such an important point, an important point for us all to always be thinking about, always be thinking, not just about, it's so easy as a researcher to seize and think, oh, it's fantastic, everybody's kind of pointing towards this, and now I've got this answer. But to always be thinking about, but what about the bit that doesn't fit in, or the person that doesn't fit in, or the experience that doesn't fit in here? What's the, what aren't we capturing? What are we not capturing? One of the questions we wanted to integrate, and we tried to integrate into the questionnaire on the hub, is to ask people at the end of their interviews, is there a question you haven't been asked which is really important? Is there something you haven't been asked that was so important about the experiences that you've had? What haven't we asked you about that might capture something central? And every project I work on, I'm trying desperately to get people to put that question in, or to put in, something into the variable. Is there something that we've left out? Yeah. Okay, thank you so much. I'm sorry, I know that we've overrun, but it's been.
Robert just had his hand up for a little while. I wouldn't mind just hearing.
Yeah.
Oh, sure, yeah.
I'll try and be super quick, and I guess it's not a question. I might be one of these kind of slightly dual experience lived experience folk in that I've got ultra rapid cycling bipolar disorder, and I'm treated with nimodipine, which is an experimental treatment. And now Professor Jeremy Hall, who Tania you know of, who's a professor of translational psychiatry at Oxford University, is leading a trial on nimodipine. He's also head of the, or made due to become head of the UK mental health research program, which is possibly the largest mental health research program in the world, given its all of the UK's research institutions. But this is a very exciting, not just for me personally. Well, it is exciting for me personally because I've had life-changing treatment from this novel treatment. It's highly, it's very likely to be, or it could be interpreted as being one of the first directly genetic treatments in mental illness because it acts on the gene CACNA1C, which controls has a role in heart function as well as brain function. And it has an effect on cognition. So it has. I'm sort of. We could end up boring you for about half an hour if I wasn't to get control of myself. But it's just a very interesting. It's particularly interesting because it's such a rare variant of bipolar disorder. As far as I know, I'm the only patient. So Alan Young, professor of psychiatry, Imperial, I think he's tried about 25 patients on nimodipine. I seem to be the only one that's responded, so I may be the only responding patient in the UK. So it's hard for clinicians, any best clinician in the world, to have a perspective on that because they don't have the data. I'm the only person with the data, so that gives a perspective on the need to involve that both sides of the coin, because otherwise you're lost. I think and then I guess on the final reflection there, the other thing I was going to say was this question of data and researchers and all of this and all of that. And the bind of mental health is that with physical health, you've got a diseased leg that you can all see, and that's quite patently obvious to us all. But as Elizabeth the First famously said, we don't have windows into men's souls, and I guess we should say into people's souls these days. But that is a challenge for researchers because you can't see into your patient's soul, and only the patient is able to do that. So that's a sort of just a final reflection that I would have, is that there's a uniqueness about the malfunction in the brain that no one else can see but the person. So that's a sort of special perspective, but I'm not sure if that takes this debate any further, but I just thought I'd splurge that out.
Well, thanks so much, Robert. I mean, thanks for sharing all of that. And yeah, no, we're looking forward to the trial and like to hopefully finding more people who may respond to nimodipine as well.
Indeed.
Because
I can't wait to
one of
meet
the
them.
things I think that it's, that's the thing. I mean, we think, well, I think it's a really important point. I mean, I think you're right. Absolutely. Everybody has this sort of everyone has a unique set of knowledge. I mean, both clinicians and people with lived experience has a kind of unique set. But I think also what's interesting is I forget, sorry, what I was about to say. It's that's it. So one of the challenges that comes up to lived experience expertise is that people will say, well, an individual only has the experience of themselves or their family member or their collection of friends or community or whatever, and that's just a limited thing. But like you say, even a clinician as eminent as Alan, as Alan Young, he's only got his experience of his sets of patients. And if one treatment works for 1 in 25 people, it may be the case that he's only treated one person who has responded to a particular treatment. But that's the great thing about research, because we can potentially go out there and we can find lots and lots of it's work for you. If we look at the patterns that you have for your particular condition and we try and recruit people who are following similar patterns to you and other people who've responded to nimodipine, then we can try and, as researchers, we can try and create, sort of get a sense, get fits, and we will have, I think that's an interesting thing about lived experience. Everybody has their unique experience, but I think also there's a lot of commonality out there. If we can just expand and meet, there will be commonalities. So for whoever has this different, that there'll be someone else out there, and there'll be more and more people. And somehow, as researchers, if we can bring everything together as a kind of community, we can find, and then we can, we can find that actually there may be a group of people who all respond to this particular thing, and then we can create something that works for that group of people. And sorry, that's also rambling, but I think I'm so sorry, but I actually have to go off to another meeting now. But I just wanted to thank everybody so much for coming along today, and for all of your questions and thoughts. And it's been a really fantastic experience, and I'm very grateful to you all for coming, and for the invite as well. Thank you.
Thank you so much.
So much.
Amazing presentation. Thank you for joining us, and thanks everyone for joining us. If anyone's not on the mailing list yet, they could send me an email to be put on the Experiential Science Talk mailing list. I put it in the chat. Thanks again, Tania.
Thank you very much. Thanks, everyone. Thanks. And do feel free to keep in touch. Thank you. Thanks.
Okay.
Bye-bye.
Bye.